Hi, I'm Dr. Karen Waller, and I'm a PhD candidate at the University of Sydney School of Public Health. Today I'll be presenting a study examining new blood-borne virus infections among organ transplant recipients using a data-linked cohort study from New South Wales, Australia, 2000 to 2015. Organ transplantation is a life-saving therapy for people with organ failure. It is limited largely by a shortage of donor organs. In Australia, there are nearly 1,700 people on the waiting list for a transplant at any time. We know in 2018, although over 1,600 people did receive a transplant, nearly 300 either died whilst waiting for an organ transplant or became too sick and were removed from the waiting list. There is a delicate balance in organ donation between trying to increase the quantity of organ donors to transplant more people, whilst maintaining the quality and safety of donated organs. The graph here shows a large increase in the number of organ donor referrals to the New South Wales Organ and Tissue Donation Service over the years 2010 to 2015. However, after taking into account the quality of these organs, only a small increase in actual donor numbers was seen over the same period. One of the concerns is the risk of blood-borne viruses complicating organ transplantations. Blood-borne viruses, particularly hepatitis B, C, and HIV, can be transmitted by organ transplantation and lead to significant complications for organ recipients. These viruses can also arise anew in recipients, and in the case of hepatitis B, reactivate in the setting of immunosuppression. Nonetheless, our treatments, as well as our tests for blood-borne viruses, have improved in recent years, and there is increasing interest in the possibility of increasing donation from people who have current or past blood-borne viruses. The true safety of these donated organs from people with past or current blood-borne viruses remains clear. In particular, there has not been any Australian data looking at transmissions or non-transmissions or blood-borne viruses. This data is quite limited due to inherent confidentiality underlying organ donation, as well as that recipients from a single organ donor would be housed in different organ transplant registries, which are specific to the type of organ donated. We aimed to understand in this study the rates of transmission and non-transmission of blood-borne virus infections, namely hepatitis B, C, and HIV, among solid organ transplant recipients in Australia. We used the SAFE-BOD data linkage study, a population-based study examining all solid organ transplantations within New South Wales, Australia, between 2000 to 2015. We included organ donors and their recipients, where both of these were located within New South Wales at the time of transplantation. Both donors and recipients in these pairs were then linked to administrative health data sets, which included hospital admissions data, notifiable conditions registries, and the death register. Using these data sets, we identified any diagnosis of HIV, hepatitis C, or hepatitis B among any data set, whether this occurred before or after transplant date, for both donors and recipients. Blood-borne virus infections that occurred after transplantation among recipients were categorised as either transmissions or other new blood-borne virus infections. Transmissions occurred within 12 months of transplant and were categorised as either proven or probable transmissions using an international algorithm based upon donor and recipient pre-transplant serology and outcomes of other recipients from that donor. In total, there were 2,120 organ donors included in this study. Most of these had a baseline blood-borne virus transmission risk, but there were 72 donors with a past or current blood-borne virus, mainly hepatitis B. Donors with a baseline blood-borne virus transmission risk donated to 3,584 recipients. After transplant, 50 of these recipients had a new blood-borne virus diagnosis, including some HIV infections, as well as mostly hepatitis C and hepatitis B diagnoses. There were no identified transmissions amongst this cohort, which is reassuring as it suggests that our categorisation of risk has been accurate and we are not underestimating transmission risk from these donors that were thought to be baseline risk. All 50 diagnoses were thought to be other sorts of new non-transmitted infections, whether those be newly arising or reactivated infections in the case of hepatitis B. Among donors with known past or current blood-borne viruses, they donated to 173 recipients. These included 24 recipients with the same blood-borne virus as their donor and 149 who were at risk of transmission from their donor. In total, 20 recipients from donors with the past or current blood-borne virus had a new blood-borne virus diagnosis themselves after transplant. These were largely hepatitis B diagnoses. There were 3 identified transmissions in this cohort, 1 proven hepatitis C transmission and 2 probable hepatitis B transmissions. There are a further 18 recipients who had newly notified blood-borne viruses that were not transmitted infections. It's worth noting that out of the 149 recipients who were at risk of transmission from their donor with a known past or current blood-borne virus, the vast majority, 146, did not have a transmission event. There were no deaths due to transmissions of blood-borne viruses, although there were 2 patients who died due to newly notified hepatitis B that was not a transmitted virus. In summary, we use this large population dataset to follow a target population of great interest due to their risk of infection, with a number of significant findings. Firstly, we found that donors with past or current blood-borne viruses were largely safe for their use in transplantation. There were very few identified transmissions, and all of these transmissions had been previously recognised by the Organ and Tissue Donation Service. Mostly, there was non-transmission of disease to recipients. And this suggests there is room to cautiously increase the use of donors with past or current blood-borne viruses. However, there were actually many other blood-borne viruses newly notified after transplantation. This is likely to be a combination of new infections as well as reactivating hepatitis B infections. There may be also some late identified transmissions occurring more than 12 months after transplantation, given the predominance of these amongst recipients from donors with past or current blood-borne viruses. Regardless, this does suggest the need for further screening for latent hepatitis B prior to transplantation with appropriate prophylaxis, as well as screening for blood-borne viruses post-transplantation, particularly given that this resulted in 2 deaths. Importantly, this study shows that data linkage can be very useful for biovigilance after transplantation. So this has provided significant novel data in the field of transplantation that was not available before this study. Thank you very much.